Another individual on that team usually is a social worker. This is someone that can help with getting a patient qualified for different financial programs and healthcare insurance programs, such as medical assistance, or in some states it's called Medicaid or Medi-Cal. They also can be very helpful in dealing with family dynamics, which are highly stressed, because everyone that loves the patient is being directly impacted in some way by the fact that she has stage 4 disease. And they're worrying and fretting, and they know they can't fix it. And being able to sit down and talk with a social worker, and even having a family meeting with a social worker, believe me, can really be quite helpful. And then another individual, which I think is important to have on the team right from the start, is a palliative care specialist. Now, those hearing this might say, oh, no, I don't want hospice care. I didn't say hospice, I said palliative care. Palliative care gets a bad rap. It's confused with hospice, first of all, though palliative care is part of hospice care. It is not equal to or meant to substitute for it. Palliative care is really quality of life preservation or quality of life restoration. Now, who doesn't want that? I want that. I want my quality of life preserved. Or if as a result of side effects or symptoms of the cancer, my quality of life has become jeopardized, I want someone to help restore my quality of life. A palliative care doctor uses opioids as the last resort. So they'll think about, let's do some spot radiation to take care of that back pain, or let's do a nerve blocker for vertebroplasty to take care of that spinal pain, and not use narcotics at all. They also are very symptom management oriented. If a patient's dealing with nausea, rather than taking them off of a drug that they need to be on, because it could be their chemotherapy agent, they'll say, well, then let's be proactive. And before you receive your chemotherapy this week, the day before, we're going to start you on an anti-nausea drug to prevent the nausea from even happening. If a patient has a poor appetite, there are medications that stimulate the appetite rather than saying, well, just try to force yourself to eat. That doesn't make any sense. So I have the utmost respect for palliative care specialists. I think they are key to any multidisciplinary team taking care of patients that do have advanced breast cancer. There may be periodic times that someone else is pulled into the team, even if it's just temporarily pulled in. That could be a neurologist or a neurosurgeon if the patient does develop brain metastasis that is going to warrant perhaps surgical removal, which a neurosurgeon would do, and the diagnoses actually might be made by a neurologist, taking a look and doing a neurological exam as well as some scans of the brain. So as we need additional experts and resources, we pull them into the team as we need them.